Welcome back to Why We Nurse. I'm your host, Serena Tobar, and today we're shining a light on a specialty that plays a vital role in diagnostics and patient care: endoscopy nursing. I'm joined by Bobby Wallace, an experienced endoscopy nurse who works alongside gastroenterologists to perform life saving procedures and provide compassionate care in a fast paced technical environment. In this episode, we'll explore what it's like to work in endoscopy, the unique skills required, and the moments that make this role so meaningful. Welcome, Bobby.
Hi, thank you for having me.
So let's start with your journey. How did you get into nursing and what led you to specialize in endoscopy?
Wow. Um, my journey into the medical field started, probably about 36, 37 years ago. I was working in a refinery and I became a industrial firefighter and a high altitude confined space rescue guy. One of the people that like rappel down ropes and rescue people off the side of buildings and
Oh,
stuff.
wow.
I did that. So being that I was an EMT, I volunteered with the local fire department and traveled all up and down the ship channel, fighting fires and rescuing people. That was my journey. I did about 16 years of that and decided that I wanted to go into a different career path. So I couldn't decide whether I wanted to be a nurse or a high school AP anatomy and physiology teacher. So I had been doing the EMT for a while, knew a lot of the emergency room nurses and personnel in the area from bringing patients there. So I decided to go ahead and go with nursing. That was my passion. The A&P teacher was spending the summers with my kids, but my true passion was nursing. I was an emergency room nurse for about 10 years, and I would go up to endoscopy and make overtime. You have the parts of the hospital where you're like, okay, I can get a consistent 8 to 10 hours of overtime every week. And the more I worked up there, the more I found out that there's way more to endoscopy than I thought. And at first they offered me a position to come in. They were like, come in and we work 410s. Well, coming from the ER, 410s, no nights, no weekends, no holidays sounded like a good thing. So I started, and then I fell in love with endoscopy. Everybody, when they think of endoscopy, they think of, oh, great, they put a camera down your throat, they put a camera up the other end of the GI tract and call it a day. But there is so much more to endoscopy than just that. So once I started it, I fell in love with it. And that's where I've been ever since.
To say my limited experience with endoscopy is having one of those cameras down my throat. I've had that a couple of times, and that's about what I know. I did a little bit. I worked on a project when we were training some doctors on a new documentation system. We had moved from one electronic health record to another. And so the doctors needed some training, and I was kind of helping them work through, like, this is how you put in your orders, this is how you do your H&Ps, et cetera, et cetera. And so I got to kind of like see a little bit in that aspect, but definitely this is a new area for me. So it's very interesting.
A lot of nurses through the hospital don't really think about endoscopy that much. And like I said, it's just a camera down the throat or a camera up the other end. And the joke that you hear is, oh, you're going to endo your career. And basically they were like, oh, that's where all the older nurses go. Really, once you get into endoscopy, you don't want to leave. If you're in endoscopy for over 2 years, you're not going to leave because you like it. I could tell you all the procedures and all the great times and all the sad times also that come with endoscopy. I don't know which route you want to go, but let me know and we will head down that direction.
Okay, well, let's start with walk us through your typical day in your role as an endoscopy nurse.
Wow, typical. We have with the hospital where I am now, we have a physician who likes to get started early. So we'll show up at the unit at 5:15 in the morning, and we start getting all the paperwork together for the inpatients. The typical get it together, make the packets, call report, and then start lining out which ones to do in what order. The physician's time is important. The patient's time is important. So we try to organize it so that everybody gets what's best for them. The physician can come in, do their procedures, and leave, and the patients all get done early enough to where if they're going home, they can go home at a decent time. We will start setting the rooms up for whatever procedures that we have, and we will bring the patients down. And in the middle of it, we're doing outpatients and inpatients. So you have to mix in the out and the inpatients, which procedures are longer, which ones are shorter. So you try to get the shorter ones done so that those patients aren't waiting while you're doing the longer cases. So that is, once we get done with that, it's charting, cleaning the scopes. And when we're done for the day, we're done for the day. There have been days that I've gone home at 10 o'clock in the morning. There are days that I've gone home at 6 o'clock at night. So we never really know what time we're going to get off until we're done.
What types of procedures would you say are most common in your area?
Wow. The most common, of course, the bread and butter are the EGDs, which is the scope down the esophagus into the stomach and just to the first part of the small intestines, the duodenum. That's the EGD. And the other bread and butter is a colonoscopy, rectum all the way around to the ileocecal valve. And those are our bread and butter. Have where I am now, we do also ERCPs. We do quite a few of those there. Endoscopic retrograde cholangiopancreatographies. Love the word, but it's just so long. You go in through the stomach into the first part of the small intestines, the duodenum, and you find the ampulla where the common bile duct comes out and go back up into it. And that's where we pull out gallstones, where we pull out stones that have blocked the passageway, or patients that have a pancreatic head mass. It'll squeeze down on the common bile duct and cut it off. And those are the patients that are sick. And you'll see them, they're bright yellow. They are bright yellow from the building up of the bilirubin. And we'll go up and put in a stent that'll hold it open and start draining out the bile. We also do bronchoscopies, which I really think bronchoscopies are really cool, where we go down into the lungs as far down as our scope can go and take biopsies, take washings. We also will do for patients that are diagnosed with lung nodules, we'll do what we call an endoscopic bronchial ultrasound, EBUS. And we go in with an ultrasound and a very fine hollow needle, and we will take core samples of the lymph nodes or whatever abnormality there is and make slides out of it and send it all off to pathology for diagnosis. Those are the basics that we do where I am now. There's so many more procedures that I've done at other facilities, but those are our basic work where I am now.
Wow, I didn't realize that there's so many procedures in endoscopy. I'm telling you, and maybe my little bit of ignorance is showing here because I'm thinking endoscopy, okay, just like you said, throats and colons, right, and not
Right.
all this other stuff, and I didn't even realize that that's where the ERCP. Do I got the letters in the right order?
ERCP, yes, ma'am.
Yes, I didn't realize that's where those were done. For some reason, I thought those were done in IR.
Right, right. You know that they have one of the places, the hospital I came from, we also did it was called a TIF. And what they do is they'll actually fix a hiatal hernia from inside the stomach, where they
Oh,
reach up and grab the lining of the stomach and pull it back down through the diaphragm and secure it to the end of the esophagus, and repairing hiatal hernias that way. They can take really tight strictures. You'll see people that just they've had injuries to their throat. They've drank gasoline. They've had some type of chemical come in and it hardens their esophagus. And we can actually go in and cut the inner lining out of their esophagus and pull it out to make it more flexible. So there are so many procedures that can be done in endoscopy. I kind of start nerding out when I start talking about it because it's all so exciting to me.
yeah. I mean, it's super interesting when you really know what's going on. So, what's your role during a procedure? How do you support both the patient and the physician?
We have where I am now, we not only round or circulate in the room, but we also tech. We also are the physician's assistant. Of course, starting out with the patients, we're bringing people from off from out in the neighborhoods and out in the street and taking all their clothes away and putting them in a very thin gown with a pair of socks on and a paper bracelet. The first thing always is the rapport with the patient. Make sure that they feel safe, make sure they feel comfortable. And, they're nervous. So me and the people that I work with are pretty good about keeping them lighthearted, keeping it in a positive attitude. So we start with the rapport of the patient and bring it into the room. We of course do a thorough timeout, right patient, right physician, right procedure before we ever start anything. Anesthesia, there'll be an anesthetist or an anesthesiologist that'll give propofol, or we have, as the nurses, we'll also do anesthesia, Versed fentanyl. So depending on what's available at the time is what we'll use. After the timeout, the patient will go to sleep, and then the tech will hand the scope to the doctor. And as the doctor is doing whatever procedure they're doing, they'll find something, find an anomaly, and they'll either want to take a biopsy of it. So the tech will hand him the biopsy forceps and then operate them and then put them in the media, or they'll use a snare. Either one of those can be hot or cold, depending on hot, using an Irby heat generating machine to coagulate whatever we're grabbing. Some of the more, I don't know how to put it, some of the more gnarly looking stuff that it looks like it's going to be very vascular, possible cancerous. When you grab it with the biopsy forceps or the snare, it bleeds a lot. So we tend to use the hot stuff to coagulate, or yeah, to as we're doing this. So we'll do that, get the samples out or the specimens out, and once the physician is done, then the circulating nurse will recover the patient back to within an Aldrete scale of within two of what they came in. Basically, when they're talking to us back alert, and then roll the patient out to recovery. And while they're rolling the patient out, the tech sets the room up for the next procedure, and we bring the next patient in.
Okay, wow. It kind of sounds similar to when we were talking to our OR nurse, you got the circulator and you got, everybody kind of has their own little role. How sterile does everything have to be within there?
With endoscopy, you can imagine where we go isn't very sterile. So it's clean and it's aseptic, but it's not sterile. We do have the one most sterile procedure that we do is placing a peg tube, a feeding tube. Once we go in and we find a good spot, a good position to put the tube, then of course, then it becomes a sterile field on the outside, and the physician will clean the area, prep, put on sterile gloves, and then proceed to do whatever he needs to do to make the hole to be able to put the feeding tube through, which a lot of people don't know. The feeding tube doesn't come from the outside of the stomach in, and we actually pull it all the way through the mouth. We bring it through the mouth, down the esophagus, and out the side of the stomach.
Wow.
Yeah, when the first time you see a peg tube come in, or being put in, you're like, that is just incredible because it's got a big bell on the end,
Uh-huh.
and it comes all the way through and then settles in up against the lining of the stomach. That's really the only real sterile procedure that we do. Yeah, because if you think of where we're going, the holes we're going into, there's not much sterility where we go.
Right, exactly. So, what are some of the key skills that an endoscopy nurse needs to be successful?
Being able to build a good rapport with not only the patients but with the physicians. You need to be able to get along with people, the doctors and the patients. That's true in any area, I know, but you're working so close with everybody and all the physicians. A good critical care nurse is a fantastic endoscopy nurse. And you're like, why? Why does it need to be? We've got these patients anesthetized, or you're doing the anesthesia on the patient. So you got to be able to watch the patient and from a critical care viewpoint as you're going through there. So a critical care nurse is really a great endoscopy nurse. People that have a good attitude is a great endoscopy nurse. Being willing to learn and being able to take advice, whether it's in a good manner or a little bit, how I don't know if you know how physicians, how surgeons are, but it is. So you need to have your critical thinking skills and the ability to have a good rapport with all your workers and the patients, the most important.
So how do you manage patient anxiety, especially like when they're nervous, they're coming in, they're going to have a colonoscopy or EGD, they're super nervous, they got a high level of anxiety. How do you guys manage that?
We talked about a little bit earlier, these people that come in, and I'll be honest with you, the female patients are a little easier to deal with because they've had a little bit more of invasive um, procedures or checkups in their life than most of the men. Even if they are nervous, talking to them, making sure that they understand everything you're going to do before you even start the procedure. I always make sure that they understand exactly what we're going to do. If they have any questions, I try to answer them as thorough as I can. And having a good sense of humor is great. The patients that come in extra nervous with a good sense of humor, they really handle it well. The men, yeah, men that are having their first colonoscopy is pretty much our most nervous patients. But again, they're the same thing. Being a male nurse in that area, kind of being able to relate to them. And I do a lot of guy stuff. I barbecue, I fish, I hunt. And in the area of the state where we are, there's a lot of guys that hunt and barbecue and fish and such. So it's easy to start talking to them and making sure that they understand that here's what we're going to do. No, you're not going to be awake for any of it. You're going to sleep through it. The medication that we use is an amnesic, so you're not going to remember a thing about what happens in this room. And always be sure and tell them that what happens in the endo room stays in the endo room. And everybody seems to like that. So
Yes. Yes. Yeah, I can imagine that it's a little bit different for a guy, especially having that first colonoscopy. So it's so
absolutely.
important though. I mean, we want to make sure that we're getting those checkups and that we're making sure that, we're catching any kind of cancers or anything early. So definitely, and I do think, you being a guy does help, right? Because we
You
can
know,
relate to that.
that is a great point that you made there about prevention. Colon cancer is so preventable. It is. Anybody, and the recommendations are anybody with a family history of colon cancer needs to start at 35. And they've moved the recommendations down for non history of family colon cancer to 45. And to be able to catch um, a polyp or an abnormality at 35 or 45 rather than waiting till 65 when you're having abnormal bowel movements or severe pain. When we can get those abnormalities taken care of at an early age, it is so preventable. And a lot of people that I've worked with, I've convinced them or I've talked to them that you just need to go get it done. And the guys are like, oh, I don't know about this. The worst part of a colonoscopy, honestly, is the day before.
Hmm.
The day before when you have the prep and you drink the drink that's the gift that keeps on giving. It's we call our patients the day before and give them a rundown. This is what you can eat. This is what you can take. Don't eat any red jello or purple jello and you're going to start the prep. And there's been a couple of times I've heard people and I'm like, where are you? And like, I'm at the mall. And I'm like, have you started your prep? Oh, yes. I'm like, go home
Oh
immediately.
my
It's
gosh.
like, do not pass go, do not collect $200. You need to get to the house. Um, and they're usually up until early in the morning, which kind of helps an anesthesiologist with them going to sleep. But that's the worst part of it is the day before. Once you get in and you're asleep and you wake up, as long as nothing truly bad was found, you're going to have breakfast or lunch, whatever time of the day when you leave there. And it's a good time to start a diet because your colon's clear.
There you go. Everything's cleaned out. You can start fresh. Healthy
Exactly.
foods.
Like we all do. Like we all do.
So, what's the most challenging part of your job and how do you navigate that?
I think we'll come in and we'll have 16 to 20 patients and the physician wants to get done by noon. We have to, it's fast paced, very fast paced, keeping up, making sure that the quality of care and making sure that the patients are taken care of. The surgeon being in a hurry doesn't matter. As long as the patient's taken care of, that's honestly our main goal with
Mhm.
all nursing. So really the fast pace is the hardest part. Doing the circulating, doing the teching, that's not the hard part. The hard part is the pace. The pace just happens. And we'll do 20 cases quickly and then we'll have 3 hours of nothing and then have two more cases or three more cases starting at 1 or 2. So there's a little bit of downtime there to get our charting done or those ever wonderful learning modules that
Never
we
ending.
get to do. So I think that would be the hardest part.
Can you share with us a story or a moment that reminded you why you love this work?
We had I don't know if it's necessarily why, I love the work because I like the patients, I like my physicians, but there have been times when we've had people that you would consider on the way younger side that were having issues. And we went in and found something that looked bad. It was something that you can tell we're not pathologists and we're not, oh, this is but once you've done it long enough, you know the difference between something that's not going to be bad and something that's going to be bad. And you can remove it. And you're able to tell this 20 something year old that, hey, this was there. We were able to remove it. You're going to be fine. You're going to be good. Those are the rewarding times. Opposite end of that is when you go in and you have the 20 something year old and you look and their colon is just completely plugged with a whatever, just a bad looking anomaly. Those are the sad times in my career, in my job.
So, what advice would you give nurses who are curious about endoscopy or procedural nursing?
I think every nurse, every floor nurse that needs to prepare a patient to come to endoscopy needs to come down and spend a day with the endoscopy nurse. We'll call to get report. And I know that sometimes it sounds bothersome, some of the questions that we're asking, but every question we ask is important. We've got to know that the patient has had clear bowel movements. We've got to know that the patient hasn't been on their Lovenox or their Eliquis for several days. Know that the patient is alert and oriented enough to get their consents. That's a big deal. Are the consents, the patients that are ANO times one, maybe two, and you're having to call the family to get consents. It's really important that we can have those before we bring the patient down, before we bring them into our unit. The physicians the physicians come to our hospital for a set amount of time. Then they have clinic. Then they have 30 or so patients that they're going to do in a surgical center. So I think bringing the nurses down just to see what we do and how important it is that the IV works. And, that sounds like a minimal thing, but when you're starting to give propofol and the patient isn't going to sleep, and then you notice that the IV was bad, we've got to know that the IV works. We've got to have the consents and to make sure that the patient understands what they're doing. I don't mind. There are some areas that'll get both the procedure and anesthesia consent. I don't mind getting either one as long as the patient's alert and oriented. Bringing them down to call the family, we will, but it's just so much easier if that's done before we bring the patient down.
Yeah, it's probably very difficult to get a whole family at 5:15 in the morning.
Oh, when the physician wants to start at 6:15 and I have to have the patient in the procedure room and ready to go at 6 o'clock. Yeah, but family members don't like being called at, like you said, 5:30, 5:45 in the morning
Mhm.
when they were called the night before and gotten the procedure. That's the thing that you'll get the procedure consent, but they won't get the anesthesia. So when you have the patient's family member on the phone, even if you don't want to get if you don't feel comfortable getting the both consents, call down to our unit, call down to endo. Somebody will either come up and talk to the family member or give us their number and tell the family member, this person's about to call you, answer your phone, and we
Mhm.
will take care of it. The patients, just like with everything, we not only need to take care of our patients, we need to take care of their family members too. If they're in house, they're sick and the family members are already worried. So when they're getting multiple phone calls from the hospital, you get a call at 5:30 in the morning, 5:45 in the morning from the hospital, you're waking up thinking the worst.
Well, yeah,
You know,
most definitely. So, how has working in this specialty shaped your perspective on nursing and patient care?
came through the ER. I've never been a floor nurse. I've done ICU. I've done the emergency room. I actually did a year in the newborn nursery toward the beginning of my career. I loved the babies. I did. I really loved the babies. And at first, I wasn't really accepted in the newborn nursery. I was a male. I was a
Mhm.
male. And why is a male coming into our area to work with the newborn babies? But when they realized that I could hold a baby with one hand and do everything else with my other hand, it became an advantage to helping them or not. Coming into endoscopy, the last hospital I came from, I was the first male to work in that endoscopy unit. And there was a nice lady that came through who was the manager before the manager that I had. And I greeted her at the door. Hey, how you doing? She goes, who are you? My name's Bobby. I work here. And she, first thing out of her mouth was like, no, you don't. I'm like, no, really, I do work here. And to her, men didn't work in endoscopy. When I left, I left as the assistant manager over that endoscopy unit. And I had several male techs and several male nurses working in the area. So I think honestly the toughest part was being a male that was coming into a predominantly dominated female area.
Mhm.
uh, once we start working together, it's a great match. If you have the patients that are a little unruly, and even with some of the physicians that have from different cultures, sometimes if you have a male in there, I hate to say that they react differently, but they do. They
Mhm.
do. So I don't know if that answered your question or not, but
No, I think it's great, and just hearing, how you're talking about, you were the only male in the nursery, and you were the only male in this endo area. It really goes to show how far nursing has come, because now I know plenty of men who are NICU nurses, and plenty. I mean, I don't think I know any endo areas that I've ever worked in, any facility I worked at that didn't have, some males in that area as well. And so I think we as a profession have come a long way in saying men have a lot to offer to this profession, um, in different ways, just like women still have a lot to offer to the profession.
absolutely. When you first started, males went to the ICU and they went to the ER. It was where you needed somebody that was strong. The guys seemed to be, super tech savvy, and that's where most of the males would go. It's so amazing to see there's not a unit in the hospital that doesn't have males on it. And you're absolutely right to see the progressiveness of this, or the females that have gotten into Lifeline. For the
Mhm.
longest time, at the beginning, it was all males in Lifeline, or you know air medicine. I don't know what you want to call it, but for what we know as Lifeline, and to see that everybody's mixing in and doing quality work, and it's amazing watching nursing. You look back and nurses were a bunch of nuns
Mhm.
working out of a church, and then you have one amazing that was like, hey, wash your hands, and started that revolution. And to see
Yes.
it progress to where it is now, it's really really great in my eyes.
Yes. And we even have male L&D nurses now too, which I think is amazing. And for
Yeah,
so long, that was like, "Oh my god, I'm a male L&D nurse? I'll clutch my pearls. What in the world?" But we have male gynecologists.
that's
We have
and that
male OBGYNs. They deliver babies. What is the difference?
exactly. When I was in nursing school a while back, during my OB rotation, the nurses didn't allow me in the rooms. They were like, "Oh, you stay here at the nurses station and you can look through the charts." and and I was like, but I'm a nurse. I'm not a male and I'm not a female. I'm a nurse.
Mhm.
Nurse first and foremost. And it was interesting to see that part of it, to where it was like, no,
Yeah.
you need to just stay in here. Yeah, one of the things that we're talking about, male and female, have you ever thought about, oh, I'm going to put a Foley catheter in this man? No, you just do it.
Right.
Yet when you're a male, they will get a female to come in to do the Foley catheter on a female. And it's like, I'm still a nurse. This is my job. This is my
Mhm.
job. This is what I do. So maybe we're getting off a whole nother subject, but it's just
Yes. So, what keeps you passionate about your work?
patience. I love my patients. I really do. I always have. I also love students. When I was over at the endoscopy unit at the hospital I came from, we had first and second semester students coming through, and they would ask to come to endoscopy. First and second semester students, typically it's here, follow this tech around and watch them take vitals, make a bed. We put them to work. We would let them go into the procedure rooms. We'd let them, you know, uh, even pushing patients on a stretcher was something exciting to a first semester nursing student. They tried to get the endoscopy area out of the rotation, but the nursing instructors were like, "No, we need endoscopy to stay in this." So the patients, absolutely, the nursing students. That's my passion. I want to make sure that the patients go home the same or better than when they got there. And I like when students come through, talking to them and asking them questions. And it's amazing to me how much most of them like being quizzed and talked to about it and asked about the procedures to make sure they understand what we're doing and the meds. So many nursing students, even toward the end of their school, aren't exactly super familiar with the meds. They'll be, okay, we're going to give this med. Okay, it's a this. Okay, what's the reversal agent? And I'm like, you don't have to know it, but you need to be able to look it up and find it. And just telling them, I don't know is an absolutely viable answer in your whole career. I don't know is viable, but always follow it up with, but I'll find out.
Exactly. Thank you so much, Bobby, for being a guest today. Endoscopy nurses are the quiet heroes of diagnostics, working behind the scenes to ensure patients are safe, informed, and cared for during some of their most vulnerable moments. Bobby's story reminds us that every specialty in nursing has its own rhythm, its own challenges, and its own heart. And that's why we nurse. Thanks for joining me for this episode of Why We Nurse. If this story gave you a new perspective on nursing specialties, share it with a friend or fellow nurse. Follow at Why We Nurse on Instagram for updates and behind the scenes content. Got a story to share or want to be a guest? Email me at whywenursepodcast@gmail.com. Until next time, stay strong, stay compassionate, and remember why you nurse.